Well, first, good morning. Good morning, everybody. Thank you very much, Charlie, for the invitation. It's a real pleasure to be with you in this beautiful setting. I come from Toulouse. Maybe you hear it when I talk. And I'm here to talk about the standard protocol of class 2 correction with TARS. For the entire duration of this presentation, this is my outline. I will explain how I came about and I came up with a protocol with a genius system. I will tell you the problems I faced in my practice, then I will talk about TARS and the use of TARS, how they help me in my daily practice. Then at the end of the year 2000, beginning of the year 2010, how I came up with a protocol. Then I will explain the unexpected benefits on growth, and then I will explain my protocol based on the genius system. After my studies, I felt that I had very few tools at my disposal: extraoral forces, directional forces, class 2 elastics, or premolar extractions. Well, of course, I managed to finish my cases, but very quickly I thought about how efficient my treatment was. I was, of course, I had a lot of difficulties with compliance of my patients. Face masks were very hard for them to wear, and I felt it was not a good idea to have them wear a face mask when they were growing, and then it would impede their sleep. And of course it was very difficult as well for the general dentist to extract premolars for occlusal reasons. So beginning of the year 2000, we do have the start of use of TARS, and I will reiterate that I think this is a revolution. Very early I tried to use them in my armamentarium. I used them in the correction of class 2. In 2006 I conducted a study on PubMed. Very few articles come up, but one article published in the Angle Journal I found very interesting, and that graph in particular. And so based on that scheme or that graph, I developed a standard protocol for class 2 correction. And this is this protocol. So it, of course, starts with molar retraction thanks to TARS. You use a coil which creates a bypass between the premolar and the canine, and this is connected in between the two roots, between the premolars and the canine. So the coil was extended by a wire and would help with retraction of the malleus. In order to test that protocol, I selected 3 cases: inclusion criteria, full class 2, and moderate crowding. This is the first case, a young boy, age 12 or 13, full class 2, with a large, with deep bite. Second one, also class 2, also deep bite. And this young girl is the third patient. I started retraction, and I had a major surprise. Maybe you remember back in those days, it was very difficult to correct a class 2. When in that case, to my surprise, my full class 2 was corrected. I understood later that it was thanks to the translucent fibers. And what came as the most surprise was the premolar retraction, which I thought was magically coming in the class 1. Now, once those premolars are in class 1, most of your work is already done for you. Then you would move the screw distally, close to the first molar. Of course, I was very accurate with my screw planning back in those days. I still am. And then I would retract the canine and premolars with an indirect mechanical system. There are 2 anchorages here, anteriorly and posteriorly, as you can see in the photograph. Then I would finish incisor retraction with bracket and wires. I would also use the TARS, and then I would change the length and the height of the hook to change the torque. The protocol worked very nicely, mind you, but it was a bit complex. Results, however, were very encouraging. My full class 2 was corrected for all of those 3 cases. Now, those are the casts before and after. You do see that the deep bite and another jit were corrected at the same time. And when you look at the side teleradiographs, What is interesting, of course, is obviously the change of class 2 to class 1, but even more impressive, in particular for the two first patients, what was really puzzling for me is that class 2 was corrected thanks to an advancement in the mandible, and it didn't sound quite logical for me. I was trying to retract on the upper arch, and yet the lower arch was advancing, so it didn't sound very logical to me. And so again, I tried to find something that would validate this thinking in literature, validated by peer reviews, journals. And so I had a look in PubMed, and I wanted to know whether if you use TADs, it had an impact on mandibular growth. A few articles, again, very few and far between. And back then, that was back at the beginning of the year 2010, I decided to select two close to surgical cases to see the impact of TADs on growth. This is the first case, a young girl, aged 13 to 14, high mandibular angle, FMA 32. When you look at the facial index, this is a borderline surgical case with bimaxillary protrusion. On the right-hand side, you also have a crossbite, red flags everywhere. So we propose surgery to this patient, but she refuses. And so we decide to go for a more original type of mechanics. We place a TAD in between 5 and 6, and inside the head of that screw, we insert a wire. So the TAD is going to be used as an anchorage with two levers anteriorly and posteriorly facing themselves as a mirror, and they are going to intrude the entire arch. So we start by inserting a round arch wire, 16, but we use a 19 by 18, and very quickly, as you can tell, there's an open bite, a posterior open bite. We continue treatment, and we place TAD at the mandible in order to avoid compensatory extrusion of molars and premolars. So you have a pseudo-surgical effect, anti-rotation of the mandible, but the chin is going to move forward. We propose extraction of the premolars to that patient to improve the face because she had lip incompetency, and so the patient agrees, and we extract premolars. So from an occlusal point of view, I'm not very happy, but this patient wanted us to debond earlier than we would have liked to. But it's very nice, the impact is very nice on the profile. So you do see that the open bite is corrected. And after we extracted the premolars, you do see that the bimaxillary protrusion is corrected, and she can close her lips. I'm going to show you the second clinical case, which is my illustration. This is again a full dental class 2 subdivision. There's a strong skeletal disharmony. You do have this open nasolabial angle, retruded chin. Staff do confirm this impression, SNB 74 degrees. And then again, we propose surgery, we propose mandibular advancement, but the patient doesn't want that surgery. So we decide to have a combined approach. When you have a short mandible, of course, we need some extra help, and so we use a propulsion device in order to help the mandible move forward. So we combine the first protocol I talked about with the second protocol. The patient is older than 16. We perform a study of cervical vertebra maturation. We do have some reservoir of growth, so it's very important that we do seize this opportunity. We do a molar retrusion, and very quickly we place a forceps contraption. Class 2 is corrected rather nicely. Very nice occlusal correction after 2 to 2.5 years. And the profile is improved, the mandible is moved forward with closed venasio-labial angle. Now you do have both SAVs, improvement of ANB, NBO, and SNB is also improved. Now, from a mechanical point of view, this is my last graph. This is just, again, a representation. In the past, I would use rather heavy class 2 elastics, and I would use many proportion devices. Those elastics, those heavy elastics, I do recommend them to use them at the end of treatment for finishing, because you get this tilting of the occlusal plane, and it's going to provide a rotation, posterior rotation of the mandible. And therefore, your correction of class 2 is not thanks to growth, but because of a tilting of the mandible. A forceps in itself is better. You do have a tilting, but you do have the extrusion of the molars. What's even better is using a forceps combined with TARS. That way, we maintain the occlusal plane, and the forceps is going to work with more efficiency. So what really happens is what you see in that animation. So from a mechanical point of view, the moment by the forceps and the moments by the TARS are just compensated, and so you just get the intrusion on the maxilla, so you get the full potential of the mandibular growth thanks to the forceps. So again, the initial question was, is there an impact of TARS on mandibular growth in class 2 patients? I think there are 4 things that make us conclude that we have that. We have more growth because those screws have a distal impact on the transversal suture. In the meantime, the mandible moves forward, so there's a catching up in between both jaws, so we do have an impact on the bone. We have again the mandible which is moving to the front. The maxilla, the mandible is also moving in the right direction, and we correct the class 2 unlocking of the occlusal plane. Leveling is possible, and in case you have a very short mandible with your propulsion device, you have better impact, because again you do cancel any unwanted effects of your forceps device. Now the further advantage of this TARS is that it completely changes your paradigm in the sequence of treatment. You start by correcting your class 2, and that way you fully benefit of the mandibular growth spurt, which is between CS3 and CS4, when again you study the maturity level of your cervical vertebrae according to Pachetti. So during all those years, I was able to find a decent protocol, very efficient, but I needed the right bracket and wire. I think I found the right system with the Jesus system. The Jesus system, I think, provides you with 4 pillars. Maybe there are more, but those 4 pillars are very interesting in my practice because there are interactions in between those pillars. Very good control of transverse dimension, good torque control, anterior and posterior torque. Posterior torque is very important as well. Also, better sliding, especially in the lateral segment, because those brackets are very passive, and light forces, because again, it's one bracket, one wire, so light forces. That's very important, especially at the beginning, especially because we use thermal wires and we can deliver light forces. Now, the Genius system helped me very much for 2 main reasons. When you recharge those molars with TARS and a coil or a spring, generally you have a distal rotation of the molars, and your arch becomes contracted. This contraction in the arch, eventually I would have a crossbite in some of my cases at the end of treatment. Thanks to the Genius system, I no longer have that. And so, because I had this crossbite, I would have to unform a wire, I would have to use a palatal root torque that would then tip the crowns, and that would be very deleterious from a periodontal point of view. I no longer have that with the Genius system. I get the right transverse transversal development. I have light continuous forces. This is an 18 by 18 square wire, and so I no longer have those problems. By increasing the wire, I control the torque, my crowns are moved inwards, and therefore I'm not having any deleterious impact on the periodontal tissues. The second main advantage is the fact that it's a fully passive bracket. In the past, in order to control the torque, I would change the different slots. I would have 18 at the front, 22 at the back. I had sliding issues. I would have to do key loops, but then it would use up my torque. That was not very logical. I no longer have that with the genius system, no issues whatsoever, better sliding. The slot is very accurate, so your anterior torque is optimized, your retraction is going very nicely with any issue whatsoever. Now, two clinical cases which I started treating at the end of year 2022, a young girl aged 13, moderate skeletal class 2. The main issue is this canine, which is impacted because there's a mesial posterior drifting of the posterior segment. Full class 2 on the right, 2 to 3 mm of class 2 on the left. Those are the intraoral photographs. We start the protocol whereby we retract thanks to the TAD and the cord, which is extended through the wire and connected to the TAD on both sides. We retract at the same time the first premolar, as you can see here, and 2 months later you see that the canine is starting erupting. So rather quickly, in March the crown is fully visible. We bond the canine in May, and those are the last photographs that I took in May, or in June rather, and it's a month completely erupted. We only used one wire, it is an 18 by 18, so the same wire has been used throughout. This is the occlusal view. You do see this canine erupt. Some spaces are being opened thanks to class 2 correction, thanks to TARS. Those are the radiographs beginning in between and interim radiograph and in June. And this is the second clinical case, a young girl, age 13. Same situation, small skeletal class 2, but strong or rather severe occlusal class 2. Those are the intraoral radiographs. Same protocol as always, and those two pictures are very interesting. Maybe you're going to notice, because you have that red mark, the second premolars I have not bonded yet. I told you that in the past the TADs were preventing the growth of the mandible. So you do see that the premolar has moved back in class 1 thanks to the transeptal fibers, and it's not too bad actually, because it does create a form of occlusion ramp, and it's going to help the mandible move forward. And those are the last photographs in May, correction class 1, molar, premolar, almost class 1 canine. Those are the arches and how they change in shape. You don't see many spaces because those transeptal fibers help the premolar move backwards. Now this is a representation, animation of the protocol full class 2, a bypass of the spring in between the first molar and premolar. Spring is activated, correction almost class 1 molar. Second premolar is flowing suit thanks to the fibers, continues to be extruded. End of correction of class 1, and also the first premolars are moving backwards, and so does the canine. Then you remove these systems, then you check your results, you bond your second premolar, you increase your wire size, you increase the torque on the anteriors, and then we're going to directly retract from the TADs to the hook. You can change the size and angle of the hook to control the torque during the retraction of the anterior segment. there we go. So two very efficient systems. One system thanks to which I can apply light forces, correct the anterior and posterior torque. I enhance my sliding mechanism thanks to the passive bracket. I have more stability in transverse development of the arch, and I find it is very important. And on the other hand, I have another very efficient tool, thanks to it I have an almost perfect anchorage, very little parasite movements, very good transversal control, and I think it does help with fully exploiting the growth potential of the mandible. So both systems, when you get them together, well, in my hands, all my complex cases become easy. Before I conclude, I wanted to show you a last photograph. This I love protocols because protocols, I think, does help you to free up your mind. Your protocols are planned. You can also better plan your schedule. 70 to 80% of our patients are class 2 patients, so it's very important to know what you're going to do beforehand. However, a protocol should not be set in or carved in stone, so you should be always looking for new options. I will be honest, I didn't know ramps. I was not used to using shorties, so I'm very much looking forward to treating this class 2 with a deep bite. I do have a retro-incisor ramp. I have studs, obviously in the molar region, and so I'm going to combine all this. With us, I would like to thank you very much for listening. Dobry Konglishi, that was my attempt at speaking Croatian. Thank you very much.